All right, class, listen up. As future clinicians, you are going to prescribe NSAIDs more than almost any other class of drug. So today, we're diving deep into the pharmacology of eicosanoids. We need to understand not just how these drugs work, but why they can have such serious and, yes, sometimes fatal unintended consequences. Let's get right into it. Okay, to really get a handle on this, we're going to use an analogy that will see us through this whole topic. I want you to think of the enzymes that produce eicosanoids as having two totally separate jobs. First, they're like the constant household managers, taking care of the essential day-to-day stuff. Protecting our stomach lining, keeping our kidneys happy, and making sure our cardiovascular system is balanced. But they are also the first responders, the ones who rush to the scene of an injury to kick off an inflammatory response. Understanding this dual role, that is the absolute key to everything we're about to discuss. So let's start by properly introducing these double agents of our physiology, the eicosanoids. Now, it's really important to remember these are not your typical hormones that travel all over the body. No, eicosanoids are made on demand, right where they're needed. They act locally and have super short half-lives, which means their effects are powerful, brief, and very tightly controlled. The synthesis of the prostanoids, which are our main focus here, depends entirely on two enzymes you absolutely positively must know: cyclooxygenase 1 and cyclooxygenase 2, or as we all call them, COX-1 and COX-2. This slide right here really lays out the fundamental division of labor. COX-1 is our housekeeper. It's constitutive, which is just a fancy way of saying it's always on, churning out prostanoids for things like gastric protection and platelet function. In total contrast, you've got COX-2, our first responder. It's inducible. Normally, its levels are really low, but when your immune cells detect an injury or an infection, its expression gets massively cranked up to drive inflammation. But here's the twist that changes the entire game. While we love to label COX-2 as the inflammatory or the bad enzyme, it's just not that simple. Turns out it also has some vital, always-on housekeeping roles, especially in the lining of our blood vessels and in our kidneys, where it helps maintain normal function. Keep this in the back of your mind. It is the key to understanding some major drug toxicities. Okay, so when a patient presents with inflammation, our pharmacological solution is one of the most widely used classes of drugs on the entire planet: non-steroidal anti-inflammatory drugs, or NSAIDs. The mechanism here is actually beautifully simple. Drugs like ibuprofen and naproxen work by blocking these COX enzymes. When you do that, you shut down the production of the pro-inflammatory prostanoids, and you basically cut the inflammatory response off right at the source. And now, this is where our simple solution gets really complicated, because when you use a drug to silence those inflammatory first responders, you run the very real risk of silencing the essential housekeepers at the same time. And the first, most classic consequence of this collateral damage is in the GI tract. By blocking the housekeeper, COX-1, we disrupt the very mechanisms that protect the stomach from its own incredibly harsh, acidic environment. This slide shows you the exact path to injury. Step 1, an NSAID blocks COX-1. Then protective prostaglandin levels plummet. Without them, the stomach's protective mucus and bicarbonate shield gets thin and weak. And the result? The stomach's own acid starts to digest its lining, leading to peptic ulcers and, potentially very serious GI bleeding. Now, this common and pretty serious side effect sparked a billion-dollar idea back in the 1990s. What if you could design a smarter NSAID, one that could selectively block only the bad inflammatory COX-2 while leaving the good housekeeping COX-1 totally alone? This was the promise of a new class of drugs called the COX-IBs. To understand the disaster that came next, we have to look at this very delicate balance happening in our blood vessels. Notice that the endothelial cells use their housekeeping COX-2 to make something called prostacyclin, or PGI2. This stuff causes vasodilation and stops platelets from clumping together. In direct opposition, the platelets use COX-1 to make thromboxane, or TXA2, which does the exact opposite. It causes vasoconstriction and promotes clotting. You see, it's a constant physiological push and pull. And here is the fatal flaw. When a highly selective COX-2 inhibitor, like rofecoxib, brand name Vioxx, hit the market, it did exactly what it promised. It shut down COX-2. But in doing that, it wiped out the protective anti-clotting PGI2. This left the pro-clotting effects of TXA2,
which is made by the untouched COX-1, completely unopposed. The physiological scale was tipped dangerously towards vasoconstriction and platelet aggregation, and that led to a huge increase in heart attacks and strokes. Vioxx was pulled from the market in what became one of the biggest drug safety scandals in history.
Okay, let's turn to our final major area of concern, the kidney. Now, in a healthy person, prostaglandins play a pretty minor role in how the kidneys function. But, and this is a huge but, in a patient whose kidneys are already compromised, say from heart failure or chronic kidney disease, these vasodilatory prostaglandins become an absolutely critical lifeline, preserving blood flow to the glomeruli.
So for these vulnerable patients, taking any NSA that blocks prostaglandins is like cutting that lifeline. The afferent arteriole constricts, blood flow to the glomerulus just plummets, the glomerular filtration rate crashes, and that patient can be thrown right into acute kidney injury. So all of this, it all leads to the central prescribing dilemma that you will constantly face as a clinician.
It is never just about treating pain. Every single NSAID prescription is a risk-benefit analysis. You have to weigh the GI risk, the cardiovascular risk, and the renal risk against the therapeutic benefit for the specific patient sitting right in front of you. This brings us to some bedrock principles for safe prescribing. First, you gotta weigh the patient's baseline GI risk from blocking COX-1 against their cardiovascular risk from blocking COX-2. Second, if they have compromised kidney function, you should probably avoid NSAIDs altogether. And finally, for every single patient, the mantra is always the same. Use the lowest effective dose for the shortest possible duration. So I'll leave you with this. Understanding this pharmacology is not just an academic exercise. It is the absolute foundation for making safe clinical decisions. For your next patient, you won't just be treating their pain, you'll be actively managing these competing risks. That's a huge responsibility, and now you're better equipped to handle it.